Hello, everyone. Welcome to the questions and answer sessions on COVID-19 organized by Science Communications of Nigeria, which is a weekly questions and answers that will be given by our invited finalists, our invited guests. With us here today, we have three invited speakers who will be answering your questions related to COVID-19. I will start by introducing Dr. Muhammad Shakir Balogun, who will be answering your questions on COVID-19. He's an expert epidemiology, a medical microbiology who holds bachelor and master's degree in medicine and field epidemiology, as well as a fellowship in medical microbiology, FMC-FAT. He also did an infectious disease fellowship with the University of Basel, Switzerland. Muhammad is a resident advisor to Nigeria Field Epidemiology and Laboratory Training Program. NFELS is a government program that trains applied epidemiologists, otherwise known as disease detectives. These are the people at the forefront of responding to disease outbreaks. He is a staff of the African Field Epidemiology Network who works closely with the Nigerian Center for Disease Control. He is actively involved and supporting the Lagos COVID Emergency Operations Center in Nigeria, especially in coordinations and surveillance. The second speaker is Ibrahim Musa Idris, who will shortly join us. He's a consultant hematologist working with Emmanuel Teaching Hospital. He holds MBBS and master's degree in public health, specifically epidemiology. In addition to the fellowship in hematology and blood transfusion, he is currently involved in COVID-rich communications through answering questions in a daily basis on a dedicated radio program titled Rayuwa the Corona, meaning living with Corona or life with Corona. The third speaker is Dr. Emmanuel Balogun, who is a biochemist and an academic staff at Ahmadu Bello University, Zaria. He also holds a visiting positions at Nigerian Institute of Medical Research, Lagos, Nigeria, and the Department of Biomedical Chemistry, the University of Tokyo, Japan. His research is focused on development of interventions against African endemic infectious diseases. Emmanuel is a recipient of numerous scholarships, fellowships, and awards. Currently, he is a member of the technical team for the COVID testing center established by Ahmadu Bello University, Zaria, and the Kaduna State government in Nigeria. You are all welcome on board to the Science Communication Hub question and answer sessions, weekly questions and answer session with us. Thank you for joining us. Our viewers, you are welcome. You can be posting your questions on Facebook and YouTube channels. We'll be starting our questions by sending this the questions that we receive from the audience, actually. We are starting by with Muhammad Shakir Balogun. This question goes to you. He's asking, many experts said that most of the COVID-19 patients don't need hospital admissions. Please, we need more clarification on this issue.
Hello, good morning. Thank you for inviting me to speak on this platform. Well, no doubt, not everyone infected with COVID-19 is actually sick and requires specific medical treatment. In fact, many infected persons show no symptoms at all. And for those who show symptoms, the vast majority have only a mild, to moderate illness, just like having common cold, something that usually doesn't require admission to a hospital. And so why do we admit everybody to the isolation center? That's the question. So we admit COVID-19 positive persons into the isolation centers for two main reasons. One is for isolation, the other is for treatment. You will notice that a lot of people refer to those facilities as isolation centers, while others refer to them as treatment centers. They actually do both. So each name has chosen to, emphasize a particular function of those facilities, but there are actually two different functions. One is an epidemiologic function, the other one is a clinical function. So why do we isolate to start with? Now we know that a COVID-19 person is capable of transmitting infection to other people. So by isolating them, you are preventing healthy people from coming in contact and getting infected. So by so doing, we are breaking the chain of transmission of the virus and stopping the outbreak. In fact, this was the method we used to stop the Ebola outbreak in 2014. All we did was to find all cases, manage them under isolation until they became negative, became healthy, or passed away. And I've seen a lot of videos of people resisting isolation in some parts of the country. I get a sense that we probably have failed in communicating the rationale of isolating apparently healthy people to these people. I think we see the isolation centers only from the clinical perspective. This is a hospital, for God's sake. Why are you keeping me here? I don't feel ill, I don't feel sick. So why are you keeping me here? And I think that if you're able to explain to them that they are there so that their loved ones and other people in the community can be protected from getting the infection, I think many of them should actually cooperate with us. And the other reason, which is treatment, the obvious reason for keeping people in hospital is usually people that have symptoms, give them supportive treatment, based on the symptoms that they have. If they're dehydrated, you rehydrate them. If they have pain, you take care of that and the rest of that. But of course, you have people who can be severely ill, has to require life support, or people that require oxygen. Some people have require mechanical ventilation. You have to intubate them. So all these things can happen outside the hospital context. And some people may actually require things like dialysis. And so now, these days, we're actually running out of bed spaces, and the government is actually looking into other strategies of dealing with people who are confirmed positive. So we are thinking of home-based care, but we know that home-based care has its own challenges that we have to deal with in terms of infection control, because if we don't manage it very well, we may end up spreading infection within households. It's a way out, but then we need to think carefully about it and implement it in such a way that we don't start having household transmission of this virus.
Thank you, Doctor. We move to the next questions. Our second question is asking, even though the lockdown is restricted within some states in the country, but the COVID is still spreading, what could be your advice to the government on this? Emmanuel, Dr. Emmanuel.
Okay, thank you very much, Umar and viewers. This is a very interesting time, and we will have to continue our discussion to be able to help our country and our society. Yes, lockdown has been advised and instituted in many states in our country, in Nigeria. There are different types of lockdown that is currently ongoing. In some states, they are basically curfew, and then in some part of the country, you have total lockdown in some states where people are not allowed or expected to go out. So, in my opinion, I will not say that these measures are really not working. I mean, or it has not been working in our country, because we have seen that the number of cases is not commensurately rising when you compare to other states, or other countries where that even got their index cases before us, before Nigeria. So honestly, I would say the lockdown really is effective. However, we are seeing a progress, a rise in the number of cases despite the lockdown. And this is because the lockdown is not total in the entire country. You have some states where you have the lockdown, and then some states where the lockdown is not effective. So therefore, the advice that we will continue to give to the government is that they should be able to conduct wide, large mass education of people, of the populace, because some people are not even really aware of the impact or of the necessity for this lockdown. So, but it is important as government. It's not only about enforcing law and order, but the government should be able to carry people along and educate them on the need to be able to adhere to the lockdown or curfew, as the case may be. For instance, I have seen the case of, there are some states, maybe I don't need to mention them for some reasons, where the governors have really we should commend them for their efforts towards stemming down the transmission of this virus. So in some states, we have complete lockdown, and really, if you look at those states, the number of cases is not improving as such. And we have seen some other states in this country where they were initially hesitant about advising towards lockdown or towards curfew to the populace in their states. And we have seen that such states, you have a rise in the number of cases and even deaths. So, by and large, people must be educated, people must be enlightened that this measure is temporary, and on the potential impact of this measure to the general populace and to our loved ones, to the country at large, because the more we are able to restrict our movements, it means we can also restrict the spread of this virus. So this is very important. So it is not only about putting blame on governments, on the federal government or the state governors, but individuals, the religious bodies, our pastors, our imams also have roles to play in educating the general populace. Of course, I believe that a synergy or cooperation between these bodies, that is the traditional rulers, the federal government, the state governments, there must be a synergy in their activities in order to be able to have a maximum impact, to be able to extend the maximum impact of the lockdown or the curfew, as the case may be. In some states, you have some days, certain number of days in a particular week where people must comply, must remain at home. And then you also have some days, a few number of days, maybe 1 or 2 days, where people are allowed to go and restock. So because this is very important, there are some peculiarities about our country or about our region, Africa, that we must have at the back of our mind. We may not be able to achieve 100% lockdown as maybe China recorded at the peak of this pandemic, and they were able to see the positive impact. So, but based on our peculiarities, we may not be able to extrapolate, just import directly measures or policies from other countries. So we must study the peculiarities of our country and then make such advice. So by and large, I would say again that government have a role to play. Government really have been commendable. I think I'll commend the governments at the various level. They have really acted. It's just that this pandemic, this disease is a very notorious one. It has really devised many rules that we have known that have been much helpful. So, but the government need to also step up its game by involving as many stakeholders as possible. In global health, interventions, the impact of our intervention is not solely the responsibility of the government or of physicians or of particular professions. Every hands must be on deck to be able to achieve whatever impact that we expect to achieve. So therefore, it's not only about government. And by the way, who is government? Individuals consider government. So we have to all put hands. We have to cooperate in order to be able to solve this problem. Therefore, there are. I understand that the government also is. There are some what they call palliative measures in which they hand over things like foodstuff to people, even some cash, that's money to people. So that's really commendable. The only thing is that there are also complaints from other quarters that these measures are not very effective. Therefore, government should also, look at what they are doing and adjust appropriately. Thank you.
Thank you, Dr. Emmanuel, for answering our questions on this. I have our audience following. Let me hover to Dr. Muhammad again. We're coming back to you. This question is asking, what is the effective use of infrared thermometer in search of an active case with COVID-19?
Okay, the infrared thermometer provides a non-contact way of measuring body temperature, from which we can know whether someone has fever or not. Now, it only tells someone that there is fever or there is no fever. It doesn't diagnose COVID-19. We know that fever is the commonest feature of COVID-19, but fever is also a feature of all infections. That is why, if you can remember, we also use the infrared thermometer during the outbreak of Ebola virus disease at airports and many places all over the country. Its importance actually lies in its use as a screening tool, because a person with fever is more likely to have COVID-19 than a person who doesn't have fever. It's quite obvious. But it doesn't mean that the person with a normal temperature can't have COVID-19, because a good percentage of people with COVID-19 actually don't have a temperature. But remember, we said that many infected persons with the virus actually show no symptoms at all, not even a fever or cough or any other thing. So the only way to confirm whether somebody has COVID-19 or not is to conduct a laboratory test. So the infrared thermometer is just a screening tool to pick out one of the symptoms of COVID-19, which is fever. So it's just a screening tool. And infrared over other means of checking body temperature. It is non-contact, meaning you can use it for so many people. It doesn't come in contact with anybody, so it doesn't have the potential for spreading infection from one person to another. So you can use it for 1,000 people. You continue using it as long as the battery, is working and that people are passing. So that's just the significance of the infrared thermometer.
Thank you very much, Dr. Mohammed. The next questions goes to Dr. Emmanuel. Does anyone with a body temperature of 40 degrees might be suspected of having COVID-19?
Yeah, thank you so much. The simple answer to this question is no. Not everyone with temperatures above 40 degrees C can be having the disease, can be infected with SARS-CoV-2. That means having COVID-19. Just like as Dr. Mohammed rightly mentioned, that rise in body temperature, which is called a fever, usually above the average, above the normal 37 degrees C, can be ascribed to many causes. Just like he mentioned, that you can have fever when you have infection by other infectious agents. For instance, you can have fever during parasitic infections, during bacterial infections. So fever is just an indication of something going wrong. It's one of the indications of something going wrong in the body. So therefore, we cannot extrapolate that directly. So the only way to confirm that, but it's an indicator, it's one of the symptoms, actually, one of the key features, apart from cough and sneezing and all those other respiratory manifestations, you also have high temperature. So high temperature, like Dr. Mohammed mentioned, help us to screen, to say, okay, if this person, because when we have a pandemic right now at hand, and the safest thing to assume is that anybody with temperature above 40 degrees C, that's anybody having fever without a known cause, can be lumped to anybody, to the group having the COVID-19. That is a safe thing to do. So, but however, those group of people will come under suspected cases. And usually what they do is that when people are suspected, they try to restrict them, they isolate them, they put them in isolation wards, and then there are samples collected for further tests in order to be able to diagnose if the disease, if the fever being experienced as a result of the virus, that is SARS-CoV-2. And that is done principally by taking samples, either an nasopharyngeal swab or oropharyngeal swab, and performing tests such as using the RT-PCR, which is generally used all over the world as one of the most reliable methods of diagnosis of COVID-19 and other viral diseases. For instance, someone with malaria, as we know, we are in the malaria endemic region. We know that this is also one of the key features, high temperature. And the reason is because why fever is associated with infections is because usually most of these pathogenic agents, either bacteria or parasites or viruses, in this case, they may secrete some chemicals known as pyrogens. And these pyrogens are agents. Pyrogens can also be secreted by the human body, but that will be as a result of assault. So these pyrogens are secreted, and eventually they find themselves around the hypothalamus, which is a region in the brain that we generally call the thermostat of the body. So when pyrogens attach there, so they kind of set the body temperature to higher temperature. And the body, when the body senses this research, the body have to do all it can within its capability to increase the body temperature. This may be some form of mechanism to be able to cope with or deal with infectious agents, because we know that most of these infectious agents, bacteria or viruses, they survive within a narrow temperature range. So the body, in order to be able to cope with that infection, so when you have that, that is also linked to what they call interleukins, what we call interleukins, which helps in raising up the temperature. And basically, the reason for this is to be able to raise the temperature such that it is the body becomes non-conducive for replication or other normal processes of the invading pathogen, that's bacteria or virus or whatever the case may be. So therefore, this is a very important thing that we have to have at the back of our mind, that at the moment, no 40 degrees C body temperature doesn't mean one have COVID-19, but we also have to be very careful, because we are in the middle of pandemic right now, and we know that this disease, this temperature, rise in temperature is a key feature of COVID-19. Therefore, it is not unlikely, or it will not be out of place to tag such a person as suspected, a COVID-19 suspect, and then to be subjected to further investigations in order to be able to confirm this disease, the presence or absence of the virus. Yes.
Let me just quickly add a little to that.
Thank you.
So even though we have said that fever is just one of the features of COVID-19, however, the presence of fever achieves extra significance in the context of COVID-19 if there are other symptoms like cough, breathlessness, or sore throat, for instance. And of course, there's the exposure history. If somebody has fever, just fever without any other thing, and has been in contact with a confirmed case, then the index of suspicion should really, really go up. Does the person work in a hospital? Is the person a healthcare worker? Is the person involved in surveillance for COVID? Does the person work in a laboratory that diagnoses COVID? With these, histories of exposure, the presence of just fever should raise one's index of suspicion that can lead to an investigation, which will include, taking a sample for laboratory confirmation.
Thank you, Dr. Emmanuel and Dr. Mohammed, for this elaborate information. So we move on to the next questions to Dr. Mohammed again. Does the virus SARS-CoV-2 have an inactive stage in the process of transmission?
The question, I'm not sure what the question means. I'm not so clear about it, but I'm going to interpret it in my own way and offer an answer. Now, if the person is asking whether there is a stage in COVID-19 infection in which the patient can't transmit, I would say yes. Because after the virus enters the body, there's an initial period within the first 2 days that it takes the virus to start multiplying and starts appearing in body fluids and so on and so forth. So during this period, the infected person is actually not infectious. The person can't transmit the virus yet because the virus is not yet present in the body fluids. And also during this period, the virus can't be detected by a laboratory test. This is usually called the latency period, in epidemiology and clinical medicine. This is very short in the case of COVID-19. It's just a matter of 2-3 days compared to other viruses like HIV, in which it can take many months or even years. Of course, there's another thing called incubation period, which is the period between the time the person is exposed to the virus to the time when the symptoms begin to appear. This period, this may be as short as 2 days or as long as 14 days, but usually within 5 to 6 days on average. So these 14-day limits that we're talking about is the basis for the 2-week follow-up of contacts. You remember that once a contact is identified, they are followed up for a period of 2 weeks. And if they develop symptoms, the samples are taken for laboratory confirmation. This is the basis for it. And of course, it's also the basis for the 2-week self-quarantine period for people returning from a country in which you have community transmission of the virus, or a person who has been exposed to the virus through other means. So this is my interpretation of the question, and I think these are the straight answers. The virus can be present in the body in the early stage, and in that stage, the person can't transmit the virus, and laboratory tests can't detect the virus. So maybe this is what the questioner is referring to as the inactive stage, where laboratory test is negative and there are no symptoms. So, and the person can't transmit. I hope I've answered the person's question.
Yeah, if I may add one more, just to support Dr. Muhammad's view, which is very appropriate and correct. There are some infections or some pathogens where you have that when they invade the animal or human, after a particular time, some of them may get sequestered in some tissues or organs where they were not naturally supposed to be resident, and therefore they are quiescent. And sometimes when the situation becomes favorable, there may be resurgence of such. But in COVID-19, I am not sure, although there is a recent study which came out not too long ago, where they try to trace trophism of SARS-CoV-2 in other organs in the body. For instance, they tried to check the brain and some other vital organs, and they couldn't find. So yeah, Dr. Muhammad is correct with that view. I think so. Yeah.
Okay, thank you very much, Dr. Muhammad and Emmanuel, for adding more information on these questions. Let's move on. The next question is to you, Dr. Emmanuel. Is African COVID-19 different from that of Europe? If not, why is the severity and date is very low compared to Europe? Are there African factors like social or environmental that have an impact on the virus, making it less deadly?
Yeah, this is really a multiple question or a complex of questions, but I'll try my best to answer them one after the other. Anyway, just simply put, the first one who says whether the other strains of SARS-CoV-2 in other regions, or specifically Europe, if it is the same as what we have in Nigeria, I would say yes, SARS-CoV-2 is SARS-CoV-2, whether in Europe or in Nigeria. Of course, we may have variations due to what we know, also that viruses can mutate very easily. But if you remember, index case, actually, well, the recorded index case for Nigeria is somebody from Italy. So and again, what is really the origin of the of this virus, of the SARS-CoV-2? Whether in Europe or in Americas or in other parts of the world, or in the Mediterranean, or in Africa, we know that it's emerged in Wuhan. So that is the primary source. So therefore, we will say that yes, this virus SARS-CoV-2 is the same SARS-CoV-2. Of course, there may be right now there are genomic studies going on to be able to see if there are substantial differences between what we have in other, comparing the SARS-CoV-2 from all regions of the world. Those studies are ongoing, and the genomic data is being updated regularly. So we will continue to look at this and study, but I would say that yes, they are the same. And so the second question, or the rider to that question, is that if not, so why is the severity very low as compared to Europe? Well, the severity, if you are looking at the severity in maybe statistically, we will say, yeah, in terms of numbers, yes, it's less in Africa as compared to Europe, because if we base our judgment on the number of new cases daily, or the total number of cases in these regions, that's Africa versus Europe, and also in terms of the number of deaths, yes, I think Africa at the moment, we are kind of trailing, yes, in terms of number of infection, so in terms of severity. But we also know that if you look at case by case, that is looking at individuals, we have a number of people who have died. So if it were that we have not had recorded maybe deaths or severity, then we say, okay, that maybe it is substantially different. But no, we have recorded deaths. Again, this is a very complicated disease in the sense that deaths can be as a result of other co-founding diseases. That means the presence pre-existing diseases in an individual. As we know, things like diabetes and co help to aggravate the impact of the disease in individuals. So, but they are basically the same. The severity, yes, we are enjoying for now, may not be as a result of pathogen factor, because in infectious diseases we talk about host-pathogen relationship. So maybe the host also have a role to play in Africa in suppressing the severity of the disease. And this suppression of severity of the disease may not be necessarily, say, immunogenic or immunologic. They may be as a result of interplay between the pathogen and environment. And this brings the third part of this question, where the viewer is asking, are there African factors that are social or environmental that are associated with reducing the impacts of this deadly disease? I will say yes, because we know that whatever outcome we see in a living organism is an interplay between genetics and the environment. So, and we know quite well that the climatic condition in Africa is much different from the climatic condition in Europe. So I am of the view, I still remain trying to be corrected, but I have discussed this many times with colleagues, that my view is that the environmental condition in Africa is really helping us. It's helping us to reduce the impact or the spread, the transmission rate of this disease, because we know that this disease, there are two major means of transmission, which is directly from person to person via respiratory droplets. You know, when people are in close contact. We also know that there's another big factor, which is due to surface contamination, infection via surface contamination. And we know from data available that the virus is a little bit heat labile, meaning at temperatures above 20, 25 to 30, that it easily gets inactivated. So maybe it helps to reduce the number of infected cases that would have been as a result of contact surface contamination and infection. So that will be my view on this in terms of environment. So the agent is the same basically as Nigeria and Europe, and also that environmental factors may have a role to play, and in slowing down the transmission. Because thus far, we are many folds less in terms of infection rate and death when we are compared to Europe. Yeah.
Thank you, Dr. Emmanuel.
Of course. Yeah. So this apparent difference in the rates of COVID infections in Africa and North America compared to North America and Europe is something that a lot of people have observed and have tried to explain. So one of the theories that people are examining right now is the issue of the BCG. That's the vaccine that we give for preventing tuberculosis. So studies have found an association between national BCG immunization programs and lower rates of COVID-19 infection. BCG is not covered by the program in several countries, in the United States, in Italy, in Spain, and those countries had a very bad run of the outbreak. And so there might be some merit in examining this further, whether it really can explain why we have this apparent, lower rate. But of course, the lower rates also, to an extent, can be explained by the fact that we have, a vastly, inferior laboratory testing capacity compared to those European countries. Many African countries can just manage a few hundred or thousand, tests per day, while those countries are doing hundreds of thousands of tests per day. So if you test more, you find more cases. So if you're looking at the rate of infection, it's probably due to the fact that we are not testing enough compared to those other places. So it's the jury is still out on that. Scientists are still working on it, but there might be some, truth behind it. And then the other thing about severity in epidemiology, we usually measure the severity of an outbreak by a measure called case fatality rate, or CFR. And this is just the proportion of people who are infected that end up dying. And in Nigeria, it has hovered around 3%, which is similar to what we find in other places. So if you're using an objective means of assessing severity, such as the CFR, it really doesn't tell us that story. It doesn't tell us that the cause of the illness is generally less severe here than in those other places. And of course, there are factors that make the disease severe, coexisting conditions like diabetes, hypertension, chronic chest conditions like bronchitis, asthma, and the rest, and emphysema, then chronic kidney disease and the rest of that. And these are things that are actually common here as well. They're not just the diseases that you find in Europe or North America, they're also very, very common here. So there's a high prevalence of those conditions here as well. So we really can't say that, the disease is less severe here than there. And we also can't say that, the rate of infection is lower here than there, because there are factors that determine what we see on the surface, which is just the tip of the iceberg. Thank you.
Okay. Thank you, Dr. Emmanuel and Dr. Muhammad. The next question is, could it be possible to use chloroquine to cure COVID-19? To Dr. Muhammad.
Could it be possible? Why not? So this question has exercised a lot of scientists and doctors and epidemiologists all over the world. So there are currently well-designed studies, to answer this question. These studies are being conducted in the US, in the UK, and China, and other countries in the world. Many of these studies are trying to test the benefit of chloroquine alone or chloroquine in combination with other drugs like azithromycin or zinc compounds. So, and I think a study is also being planned for Nigeria. We need the outcome of these studies to be able to answer this question, to make this decision. Studies like these form the scientific basis of medical treatments. For any treatment to be acceptable, it has to go through what is known as a randomized clinical trial. And many previous studies conducted to see whether chloroquine or its sister compound hydroxychloroquine can be used in treating COVID they were technically inadequate. They did not measure up to the gold standard experimental procedure for making a decision like this. So they can't be relied upon. That's why we have this large number of well-designed studies that are being conducted all over the world. For chloroquine or hydroxychloroquine to become a standard treatment, they need to be shown to be more effective and also safer than other treatments available, and also safer than giving nothing. So if giving chloroquine brings more harm than good, then it's useless, it won't be acceptable. So these are the studies that can answer this question for us. And if they don't show any additional benefits, they're more harmful, they will not be accepted. So these are the issues. So chloroquine, as we wait for these studies, the outcome can point in either direction. The outcome can confirm the hypothesis that chloroquine, of course, to test for this kind of thing, the drug has to go through several trials, to check for the efficacy in the test tube. Can it even do anything to the virus at that level? Can it do something in animals? Is it toxic, and the rest of that? So chloroquine has been with us for a very long time, so it has passed through all these stages. That's why we're at a very advanced stage of the trial. We're at phase 2B clinical trial, which is to actually show whether it works or not. So there are studies going on all over the world, so we'll wait for that. But COVID-19 is a brand new virus, no previous experience with treating it. So people are throwing all sorts of things at it. People are throwing antiviral drugs at it. People are talking about remdesivir. In Nigeria, in many isolation centers, we have used things like ritonavir, combination, which is actually used for HIV. But there is actually no evidence for the use of these, because there is no clinical trial that shows that these things actually work. People are just using them. So it's the clinical trials that will actually answer our question. This is the difference between medicine and what herbalists do. You just pick anything and give to people. We have to really know what exactly is happening. We have to be able to demonstrate that this drug actually works and it is not harmful before we can start prescribing to people, before it can become a standard treatment in our treatment centers. Thank you.
Thank you very much, Dr. Mohammed. And next we go to Dr. Emmanuel. What are the next available options now that the lockdown is not obviously working?
Yes, that is really a very tough question. But again, I will mention that we should not be categorical. We should not categorically say that the lockdown is not working or has not worked. I think all over the world we will say that the lockdown really has worked. It has worked in some regions of the world, and if applied properly anywhere else, it will also work. The only thing is that based on the peculiarities of societies, then we will experience the natural differences that we are seeing. But however, I would say, yes, I have also been wondering and pondering. I have listened to a number of questions from colleagues and students that for how long are we going to be locked down? Because it appears nobody is able to, most of the countries are not able to answer this question, clearly. So I would say that I think we just have to observe a little bit more. Maybe we can endure a little bit more in just a matter of a few weeks. And then because we have made progress really all over the world. This progress has been recorded in terms of curbing the transmission of this disease. Really, again, I must say that many countries, and including ours, we need to be commended for the efforts by our people. So, and we have seen that also there has been really impact on the economy, on the ways of lives, on health, on mental health, and on many things of people, all over the world, in our country particularly. So therefore, I will say that very soon, but I don't know how soon this soon will be, is to begin to ease down the lockdown. Easing the lockdown doesn't mean we should just go back recklessly. It will mean that we should apply what we have learned in this process. At least we have seen that improvement of personal hygiene, that is practicing good hygiene practices, good hygiene is very helpful. And this is what we know right from long ago, that improvement in personal hygiene helps reduce infectivity rate by infectious diseases. So therefore, we should continue. The lockdown should be eased. As for instance, I think in some states in Nigeria, for instance, Lagos, I think Abuja and Ogun State, there has been some ways of easing that the government have used to ease down the lockdown, which is really good. But we should also continue to educate our people that although we are easing the lockdown, it doesn't mean we should go back to recklessness of lack of hygiene. But specifically, I'll mention a few of these kind of things that we need to change about our lifestyle. For instance, greetings. In Nigeria or in Africa, we shake a lot. So this really should be become virtually zero. Things like hugging and close contact should be a thing of the past for now. Therefore, I will also advocate that in order to be able to go back to normalcy, so this lockdown should be in phases. We know that elderly people are much more susceptible, or the fatality is higher in elderly people above 60 years of old. So therefore, such people may not be immediately integrated after the open up. So such people may continue to work from home, and then we say, okay, for those who are less susceptible, for which this disease is less fatal, or that's the young people and people without comorbidities, they can go back to work. And I would recommend that, people should continue to use the face mask. And in addition to that, if it is possible, I'm just visualizing this, that people can go back to work normally. Just imagine a situation in which you walk into a banking hall or a company and everybody is on his mask. And then in addition to that, you have the face shield on, because there are very light face shields that will be comfortable to use. So because we have to be careful that we don't open up and then the disease overwhelms us. So we must be able to find out ways in which we can go back to normalcy without aggravating the potential negative impacts of the disease. So we should go back. There should be schools should open up in phases. And also, every child or every student going back to school, whether at whatever level in education, whether university down to elementary, students should be encouraged to use their mask, practice frequent hygiene, no shaking of hands and all that. And I believe with this, this will help us, will be a potential help to what we are experiencing at the moment, because this lockdown is really not sustainable. We cannot continue like this. Businesses are crumbling, people are losing their jobs. Therefore, we have to rethink and go back wisely. Yes. Yeah.
Thank you, Dr. Emmanuel. The next we are going to Dr. Mohammed. Please, is there any way to reduce the spread of this coronavirus, taking into considerations that staying at home is becoming a difficult thing for our people?
So, so this question is similar to the what do you call it, the lockdown thing. Is that not so? Yeah, it sounds like the lockdown question. So the thing is, we have seen what has happened in many countries in the world. We have seen what happened in China. Before China could surmount, could conquer the outbreak, could control the outbreak, it actually had to impose a lockdown for like 76 days. 76 days in Wuhan. We didn't come close to doing that in Nigeria. And even when we did it, we didn't do it very well. So when people say that lockdown did not work, it's just like when you prescribe 4 tablets of chloroquine to a person and they take only one and they say, oh, I'm still having fever, I'm not feeling better. You're supposed to take 4, you've taken just 1. So you can't claim that the drug is not working. But then the next question is, can we really do the level of what the Chinese did? That's a question that I can answer. But if you don't do that level of it, I don't see how we can bring it to that level that enables us to open up and allow people to move around. We saw what happened in many countries in Europe and North America. In the United States, as they were lifting, relaxing the restriction of movement in many states, cases started going up. So from a strictly epidemiologic point of view, I don't see how we can control this outbreak without doing a lockdown, accompanied by other things like active case finding, contact tracing, and isolation. I don't see how it's going to happen. When we had the lockdown, we're having cases. We have relaxed the lockdown. Cases are even increasing. So do we expect the cases to come down by magic? But of course, I understand that for the government, the decision goes beyond just epidemiology. There's also the economic consideration, like Emmanuel mentioned, that the economy is getting crippled, families are getting pauperized, people are going hungry, millions of Nigerians, and they're living on a daily basis. So if they don't go to work, but at the same time, the science is telling us that if we don't impose this restriction of movement, we cannot control this outbreak. It's going to be here for several years. People are going to die. That is the truth about it. It's happening in many countries already. If you allow it to let loose, it's going to kill a lot of people. We really need to restrict the movement of people and do a lot of case finding, isolation, contact tracing, and the rest of life. If you don't do that, I don't see how we're going to succeed. So it's left for government to look at the other options. The government can't change, the behavior of the virus or the behavior of the outbreak. That is the science. That's the epidemiology. What the government has power over is to see whether the lockdown can be implemented more effectively. We need to know what are the impediments to the effective implementation of a lockdown and how can we deal with those things. So those people that have very meager means that need to go out on a daily basis, is there a way the government can take care of their needs such that they don't go out until we control this outbreak? This is an honest question that the government needs to ask itself. Otherwise, people are going to die, and I suspect that a few weeks down the line, we will scamper back into our homes. People are going to impose another lockdown as cases continue to increase and the government gets scared. So these are tough questions. I don't have a particular advice. I can only speak from the scientific perspective. It is left for the government to see what it can do with regard to the economic aspect, with the humanitarian aspect, the security issues, because you have once you impose a lockdown and palliatives don't get to the people that need them, there's going to be a groundswell of anger, of agitation, of discontent. Criminal activities will increase. I think these are things that are within the power of the government to take care of. Otherwise, the virus doesn't care about you. It doesn't care whether you're a poor country or you're a rich country. It will continue to ravage our people if we don't restrict movement. Now that lockdown has been relaxed, you see what people are doing. Buses are packed full. There is no social distancing anywhere. You go to the markets, there's nothing like that. You go to the banks. So we have increased the opportunities for people to exchange virus and increase, the transmission of the disease. So I don't see, except we're expecting a miracle or some kind of magic to just put a stop to it. Like the president of one country said that the virus will just disappear like that one day. Maybe we're going to have that kind of miracle. But if you're looking at the science, I don't see how the number of cases will come down if you continue like this.
Thank you, Dr. Mohammed. As we go over to Dr. Emmanuel, can this COVID-19 be like an airborne disease?
Yes, at least based on data available, the answer is no. Initially, I think there was a time WHO recommended that this should be treated as an airborne disease, but studies have shown that it may not be an airborne disease. Airborne diseases are diseases that can be transmitted through the air. So it means that when they are expelled, diseases like TB and varicella zoster, and a number of other, even measles. I think measles is in that category, if I'm right. Maybe Dr. Mohammed can comment on this later. They are diseases that can be transmitted. So meaning their pathogen can remain suspended in the air for a long time and still remain infective or infectious. So, but I have seen a number of study and consideration and also simulations that have proven that with regards to this disease, that's COVID-19, so the agent, the pathogen, SARS-CoV-2, is expelled from an infected individual as droplets, not as aerosols, substantially. Of course, we cannot rule out there are under certain conditions in which aerosols can be generated, but usually when you're looking at an infected person to another uninfected person, is usually transmitted through droplets. And droplets are like expelled substances, basically moisture or saliva or through cough or sneezing. And these droplets are known to be of sizes above about 10 micrometer. So, and that is why, so because of this, the size, it cannot remain suspended for too long in the air, and it cannot travel too far because gravity acts on it and it falls down. And that's why we have been, that's the reason behind the advice of keeping 1 to 2 meter distance from each other, so that in case one is infected, even when the droplets containing the virus are expelled, it falls off before it gets to the next person. Of course, this doesn't mean we should not continue to use face masks. It is very important to continue to use them and also practice hand hygiene, and also avoid overcrowding. Even so, but basically, based on the description and definition of airborne diseases and their characteristics, I think COVID-19 is not strictly under this categorization. Yes, because it comes in droplets, and droplets are of big size and easily can come down as a result of gravity. And I have seen a number of studies where they have shown that when droplets are expelled after a certain time interval, they check the air, that's the environment, to see if you have the infective or infectious virus suspended. The answer is no from those studies I can remember vividly. Yeah.
Thank you very much, Dr. Emmanuel. The last questions we have for this week, questions and answer is it really true that if you are close to a person with COVID-19, air can easily circulate the virus to your body?
Is this to me?
Yes.
Okay. Yeah.
Okay. So COVID-19 is transmitted, as we know, when you come into close contact with somebody who is infected. The virus leaves the body of the infected person when they cough, sneeze, or even when they speak. And the virus doesn't travel very far, like Emmanuel just explained. So once they're expelled, the droplets drop to the ground. And so you have to be really close to the person, within like 2 meters, for effective transmission of infection to occur. And this, of course, is the basis for the social distancing, that we talk about, that we should leave a distance of 2 meters between individuals in order to reduce the probability of infection happening. So if one is in close contact, the virus can enter the body through the nose, through the mouth, and there are studies now pointing to the fact that even through the eyes. And that's the reason why people that work in high-risk situations, people that take samples from confirmed cases, from suspected cases, people that treat confirmed cases, they're expected to wear goggles, they're expected to wear face shields in order to completely protect all the different portals of entry for the virus. So, and this is why we use things like face masks. And it is important, talking about face masks, it's important for both the infected and healthy person to wear the mask. In actual fact, it's actually more important for the infected person, because when they talk or cough or they sneeze, the face mask helps to keep the droplets in. And of course, some of them still find their way out. And that's the other barrier for the person who is healthy, so that they don't get infected from the little that comes out. So both the person that is healthy and the person that is infected need to use the face masks. And it's another possibility for transmission in terms of droplet infection is when somebody coughs or sneezes or talks. These droplets can actually fall on a flat surface like a table or a book or even a phone. If somebody else comes and touches any of those things and now takes his hand into his face, touches his face, the virus can find its way through the nose or through the mouth or through the eyes. And that's the reason why we talk about wash your hand, wash your hand, wash your hand. You don't know who has dropped viruses where you have touched. So as frequently as possible, wash your hand. All these things are based on the science, on what is known about how the virus is transmitted. And this is how the science is also applied as well. The use of social distancing, at least 2 meters, the use of face masks, the use of face shields, the use of goggles, and of course, hand washing. So the science and the practice are tightly linked to each other. The practice is based on what we know so far about how the virus is transmitted. So it's correct, if you come close to a person, you have a lot of opportunities for getting the infection. And these are the barriers, these are the ways of preventing an infection occurring.
Yeah,
Thank
and
you
maybe
very
just
much.
to add,
Okay, go ahead.
just to add for 30 minutes, maybe 30 seconds, just to add, because we cannot overemphasize the need, just like Dr. Mohammed had mentioned, the need for frequent hygiene, that is washing of hands and being careful not to touch our faces. So it's very, very important to do this, and we must do it properly. Because I was in a workshop recently, and I found out that I've actually been washing my hands in the wrong way. So I think people, maybe the governments, or we have been doing that on our part as educationists, trying to enlighten our people on how to wash the hands properly using the right. It's very easy. So can deal with the virus because of the science that we know about this. So please, let's find out, take our time to find out and ask, how do we really wash our hands properly when we come very close to people that are potentially infected or in a crowd? Yes, thank you.
Yeah, thank you very much, Dr. Mohammed, and thank you, Dr. Emmanuel, for adding more elaborate information on this. This has come to the end of our questions and answer sessions today. I will quickly go into our audience to see some questions. Maybe we can pick 1 or 2 questions for you to answer. And we have one question here, I think, that will be relevant more to Dr. Mohammed. Shehu Mohammed Hassan is asking, is it possible to get reinfected with COVID-19 after treatment? Dr. Mohammed.
So, so the talk about yes. So the talk about reinfection has been going on for a long time, and I think it started when some people who had tested negative in the course of their treatment were also subsequently found to be positive. But then another study found out that those were actually false positives. So there is no evidence to show that reinfection can occur. But at the same time, it has not been firmly established that infection actually offers adequate protection. So we are still, studies are still trying to establish those, to know whether once you've been infected once, you are protected for life, like you have for many other disease conditions, things like measles and the rest of that. But my own hunch is that the virus seems to be very, very strongly immunogenic, and a lot of its pathologic features, meaning the way it causes disease, is actually mediated by a very strong immune response from the infected person. So I have the hunch that infection actually offers protection, but the jury is still out on that. Studies are still going on. The virus has not been around for long enough. The outbreak just started in December, so we need enough time to know whether we can actually have adequate or even long life protection from getting infected. But there has not been any validated instance of reinfection after somebody has cleared the virus.
Thank you very much, Dr. Mohammed. The next questions we have by Abdulwahid Oyawale. Please, what do you have to say about the claims of Dr. Remo in regards to treatment of COVID-19 to malaria? Dr. Emmanuel.
Well, it's a claim for sure at this level, because it's still it has not been this issue we have discussed. Dr. Mohammed has discussed this adequately about claiming. He mentioned, I think he cited hydroxychloroquine and all that, and anti-malarials. So, but this is we cannot discard such claims, really, because they should be subjected to good scientific investigation, because it's not only Dr. Raymond Okwesi who claimed this. I think there's also some governors in Nigeria that claimed that when they were treated for malaria, they became fine. So we will continue to investigate this further. We cannot disprove them for now, but we do not have the scientific evidence to say adequately that the treatment they were given was really effective against COVID, even though it was for malaria. But however, I will also mention that there was a study, I think it was published in Nature a few weeks ago, where they found that the severity of the lack of severity of COVID-19 in Africa, it kind of mirrors is a mirror image of malaria endemicity. So maybe these things have some relationship. At this moment, it's still too early to say it is not. And it's also too early to say that it is, because we must, as scientists, we must investigate to be able to say yes or no. Yeah.
Okay. Thank you very much, Dr. Emmanuel and Dr. Mohammed. I think that has come to the end of our today's sessions, question and answer sessions. For our followers, viewers around YouTube channels and Facebook page, please kindly put down your questions. Your questions will subsequently be answered in the next week or so. We'll go over to your questions and answer them by our next speakers. Thank you for your time. Thank you for being with us, Dr. Emmanuel and Dr. Mohammed Shakir. Nice having you here in the studio.
Thank you for inviting me.
You're welcome, sir. Yeah. So hope to see you for tomorrow's Hausa's version.
Yes, we will practice Hausa before tomorrow.
Okay. Okay, bye.
Thank you.
Bye-bye.
Bye.
Bye-bye. All right.